In this lecture, we are going to cover some of the general diseases and abnormalities of the digestive system. The digestive system comprises the alimentary canal, or the digestive tract, as well as the accessory organs of digestion, which you can see in the figure here. Each unit or organ of the system must be normal in structure as well as function in order to regulate the ingestion, digestion, and absorption of nutrients. The alimentary canal processes and transports the products of digestion. The accessory organs, which are located outside of the gastrointestinal tract, or GIT, manufacture and secrete both endocrine as well as exocrine enzymes, which are essential for the breakdown, digestion, and absorption of nutrients. So please take a minute to look at this figure here and understand what the main organs of the digestive system do, as well as the accessory organs, and understand the process of ingestion and digestion. So when we ingest food, it comes into our mouth and we start to salivate. Our saliva will help to break down that bolus of food, as well as the process of mastication, chewing. When we're able to swallow our food, the pharynx is going to be responsible for that, and food is going to travel down the esophagus and enter into the stomach. From the stomach, it's going to leave through the pyloric antrum of the stomach and go into the small intestine. Small intestine is comprised of three segments: the duodenum, the jejunum, and the ileum. And then after the small intestine, it's going to leave and go into the large intestine, travel through the ascending, transverse, and descending colon before it hits the sigmoid colon, which is this little bend right here. And then it's going to leave via the rectum and anus through the process of defecation. So that's the whole process of digestion and where food enters and where food leaves. As I mentioned on the previous slide, our teeth are involved in the process of mastication. And you can see our 32 teeth depicted in the picture on the right. So mastication, or chewing, the whole point of that is to break down food into pieces that can be swallowed and digested easily. So if the chewing function is hindered by decay or infection of the teeth or gums, or some type of mouth pathology or missing teeth, this can hinder the process of digestion. Let's begin by talking about xerostomia. A decrease in saliva production, that's what xerostomia is. And this can adversely affect the digestive process. And this can be caused by dehydration, certain medications, and even over-the-counter prescriptions. And this can also be caused by a condition known as Sjogren syndrome. So that's pronounced Sjogren syndrome. And in Sjogren syndrome, you get dry eyes and a dry mouth, and sometimes the patients present with a condition known as halitosis, or bad breath. Inflammation of the gums is known as gingivitis, and when we get cavities, those are known as dental caries. So most of the disorders that affect the mouth, they're not serious, but they need to be treated because these can lead to more serious complications down the road. So the first viral pathology that we're going to talk about in this class is herpes simplex virus 1. And this is the virus that causes cold sores that you can see in the picture here. So the cold sore blisters can develop on the lips, inside the mouth, and these produce painful ulcers that last a few hours or days. This usually resides in about 2 weeks. There are antiviral medications and there are certain creams that you can put on to help accelerate this process. But anytime the patient's exposed to the sun for an extensive period of time, a strong wind, excessive stress, and if the patient uses nicotine or alcohol, these can all exacerbate or cause the herpes simplex to erupt. This is a virus that's going to remain latent, so once you get herpes simplex virus 1, you're always going to have it. It's not always going to be visible, but it's always going to remain in your cells. Sometimes the patients are going to report tingling and numbness around the mouth where the cold sores are, and it's really important for the patients not to pick at these cold sores because they can result in scarring. So again, the pathogenesis of this usually lasts The pathogenesis is caused by a viral infection, and the visible symptoms usually last about 14 days. So in a diagnosis, the way it's going to be diagnosed is through oral examination. And it's very important for the doctor who's doing the diagnosis to isolate the HSV1 from local lesions in order to confirm the infection. This is usually done via biopsy, and then it's sent off into a lab. Unfortunately, there's no cures. But again, like I said earlier, cold sores usually clear up uneventfully in about 7 to 14 days. So it's really important to educate your patients. If you become a medical doctor and you come into contact with patients who have HSV1, to educate them about the fact that this virus is highly contagious and it can be spread. So you can recommend to your patients to avoid close contact between other people. That includes kissing, because the virus remains latent in the saliva even after the vesicle has healed. The next condition we're going to talk about is thrush, also known as oral thrush. And this is candidiasis of the oral mucosa, and it can involve the mouth, the tongue, the palate, as well as the gums. And this is due to a fungal infection, it's due to the fungus Candida albicans. And this is a relatively short-lived infection, but it produces these sore, slightly raised, pale yellow patches that you can see in the picture here. So kind of looks pretty ugly in this picture here, but this is the result of thrush. This is the result of the fungal infection. So sometimes these lesions can actually cause a burning sensation in the mouth, and they can be painful when they are irritated. So be very careful when you can advise your patients to be very careful when they're brushing their teeth or when they're eating, and just a little bit of irritation can cause bleeding to occur. Some of the patients who have severe cases of thrush may actually have the smell of yeast in their breath. Thrush most often develops in young children. It can also be seen in patients who are immunodeficient, and it can occur in older adults as well. So it can really occur at any age, but it's usually common in young children. This is a condition that's usually easily resolved through a combination of antifungal medications, nystatin and fluconazole. So a 14-day administration of these antifungal medications usually resolves oral thrush. The original diagnosis is made by either a dentist or a physician or a healthcare provider when that person is doing the oral exam. And then the diagnosis is going to be confirmed by sending a biopsy or an analysis of the sample from the lesion. So what else? Other than that, that's pretty much all you need to know about oral thrush. When you teach your patients about oral thrush, it's really important to educate them about the diet and what they can and what they can't eat. So they shouldn't be eating any foods that are very difficult to digest or foods that may cause a lot of irritation. So avoid any really tough foods like meats and things that have to be chewed extensively. And also, if you become a dentist, you can recommend to your patients to use a soft toothbrush and be more conscientious of oral hygiene. Oral leukoplakia, which can be seen in this picture as this white lesion that I just circled in the inside of this patient's mouth, is due to hyperkeratosis or epidermal thickening of the buccal mucosa, the palate, or the lower lip. So again, this is just a white plaque that's thickened and hardened, and it's a part of the mucous membrane in the mouth. Usually takes several weeks for this to develop, and it can vary in size. They can be smaller, they can be very large. At first, the patient is relatively asymptomatic, but as the leukoplakia progresses and gets larger, the mucous membranes can become rougher, harder, and whitish gray, and they can become very sensitive to hot or spicy foods. And this can develop at any age, but it's more commonly seen in older adults. And it usually results from some type of chronic irritation, such as habitual or chronic friction by biting your cheek, biting your tongue excessively, the use of dentures, or a rough tooth that is basically just rubbing away and irritating that area raw. Leukoplakia may also be a reaction to the heat from tobacco smoke or local irritation from chewing tobacco, so patients should avoid tobacco. Everybody should avoid tobacco. Tobacco has no true beneficial health aspects to it. So it is important to monitor the size of this lesion, because this lesion can progress into a malignant cancer. So malignant transformation is possible, so it is very important to consult a healthcare provider and get a true diagnosis and get treatment for this. As I mentioned on the previous slide, that oral leukoplakia can turn into cancer, so it's very important to monitor. So on this slide, we're going to talk about the different types of oral cancer. Oral cancer is going to be predominantly the squamous cell type, so 90% are squamous cell carcinomas, and then the remaining are usually some type of adenocarcinoma. And these cancers can occur on the lips, the cheek mucosa, the anterior tongue, the floor of the mouth, the hard palate, as well as along the gum line. So usually early on, the cancer is painless, and this may be seen when the patient's brushing their teeth or just looking at the inside of their mouth. You can see all this white area here. This is all cancerous cells. So again, as I mentioned, it's usually painless early on, but what is actually going to bring the patient in to see a physician is they're going to be complaining of pain eventually. So they can have dysphagia, which means difficulty of swallowing, odynophagia, pain when swallowing. The patient may notice that they're losing weight. They may have excessive bleeding when they are brushing their teeth or eating, or they may say that they're having some type of referred pain to their jaw or their ear. They may also notice that they're losing their teeth, or they are having excessive buildup on their dentures. So again, like I mentioned, about 90% of the oral cancers are of the squamous cell type, and the lip is the most common location of oral cancer because it has the risk factor of sun exposure. And again, don't drink, don't smoke. Those are two very bad things for you. All they do is cause cancer and cause many other problems in the body. So those who smoke and those who drink have 15 times higher incidence of oral cancer compared to those who do not. So the use of alcohol and tobacco, especially cigarette smoking and snuff dipping, that accounts for up to 80% of cases of oral cancer. And the combined effect of alcohol and smoking is multiplicative. Betel nut chewing is another thing that can cause cancer. This is a common practice in Southeast Asia and in Micronesia, and this can also cause an increased risk as well. Now we're going to move into diseases of the gastrointestinal tract. So again, the alimentary canal, or the GIT, is a hollow continuous tube that extends from the mouth all the way down to the anus. And it's responsible for propelling the food for digestion by a process known as peristalsis. Peristalsis is a coordinated wave-like muscular motion that forces food along the alimentary canal. It's also the site of the processes of mechanical and chemical breakdown of food. So as the food passes through the tract, it's broken down into molecules that can be absorbed through the intestinal wall for distribution of body cells for metabolism via the bloodstream. So the first gastrointestinal pathology that we're going to talk about is known as GERD, or gastroesophageal reflux disease. And what GERD actually is referring to the clinical manifestations of regurgitation of the stomach and duodenal contents into the esophagus. So we have these esophageal sphincters. So this sphincter opens up when we are swallowing food, and it allows food to pass from the esophagus into the stomach. And then when we are digesting the food and no longer intaking food, this sphincter can close. So what happens is this sphincter can become weakened and become irritated, and it can open when it's not supposed to. And what could happen when the sphincter is open when it's not supposed to is all the contents in the stomach can rush and backflow up into the esophagus. GERD usually occurs at night, and the patient may say that they're experiencing heartburn. It may be very bad in some patients. Some patients may say that they're experiencing a heart attack, but it's usually heartburn that occurs due to GERD. And the patient may also report coughing spells and wheezing due to the irritation of the oropharynx or the respiratory tree. The patient may also say that they vomit into their mouth several times. The vomit could happen if the food is propulsed or the stomach contents are propulsed up too far. So this, as you know, the esophagus is in direct connection with the mouth, and these contents can get projected back into the mouth. So the patient may say that they're throwing up in their mouth. GERD can be due to overeating, it can be due to pregnancy, and even weight gain. GERD that usually causes pathology is frequently associated with relaxation of that lower esophageal sphincter that I mentioned earlier. So again, that sphincter is going to become weakened, it's going to be opening and relaxing when it's not supposed to. So what can these patients do? Well, they can elevate their head when they're sleeping. And what that's going to do is basically allow for gravity to help with keeping the stomach contents where they should be. The patient should be encouraged to eat a light evening meal, not eat any heavy meals, especially really spicy meals. Antacids can help prevent the symptomatology of GERD. And again, limit the tobacco and alcohol use, because tobacco and alcohol can exacerbate GERD. On this slide, we are going to talk about esophageal varices, which are dilated submucosal veins that develop in patients with underlying portal hypertension, and this condition can result in serious upper gastrointestinal bleeding. So what actually happens in this pathology is the superficial veins lining the esophagus become dilated and twisted at the distal end of the esophagus. And you can see what happens here. If the veins become twisted and dilated, it can actually lead to obstruction. So this is a radiographic image of an obstructed blood flow in the esophageal vessel. So you can see that obstruction of blood flow, that blood is just kind of stuck right there, and it's depicted by that darker black content. Variceal hemorrhage is something that you have to be very cautious and aware of in patients with esophageal varices, because the patients are going to be relatively asymptomatic until that stage. So they are asymptomatic until these varices rupture. When the varices do rupture, this can be life-threatening and is a medical emergency. If the patient's not already hospitalized, you need to get that patient to the ER as soon as possible. These varices actually result from increased pressure within the veins, and this pressure develops when the venous return to the liver is impeded. Esophageal varices occur in about 2/3 of all patients with cirrhosis of the liver and are often associated with alcoholic cirrhosis. So how do we diagnose this condition? Well, it's based upon the clinical picture and the history of hepatic disease, specifically cirrhosis. They're going to do radiographs like the one in figure A to look at if there's any obstruction or dilation. They will also do endoscopies, and they may even do histology to look at dilation of specific veins. The principal treatment of a patient with bleeding esophageal varices is the same as that for any patient with gross GI bleeding. Replace the blood volume and maintaining the fluid and electrolyte balance in order to restore homeostasis. Two other conditions that may occur due to esophageal varices, this bullet point right here: hematemesis, which means throwing up blood, or melena, which means that the patient has dark, tarry stools. And as I mentioned, this is a medical emergency. The patient can go into hypovolemic shock. So again, immediate medical attention is warranted for this condition if the varices rupture. Esophagitis literally means inflammation of the esophagus and its tissue. So the main symptom that the patient is going to experience in this condition is heartburn, which can make the patient believe that he or she is actually having a heart attack. And the onset of pain typically follows eating or drinking. The patient may even have some vomiting of blood, that condition known as hematemesis that we talked about on the previous slide, present as well. So with esophagitis can come reflux as well as defect in the lower esophageal sphincter. So again, we talked about that in GERD, how that lower esophageal sphincter is relaxing when it shouldn't be relaxing, and contents are being refluxed back. Corrosive esophagitis is what you see in this picture here, and see all the corrosion to the esophagus. And this is severe inflammation of the esophagus resulting from ingestion of a caustic chemical, such as an alkali or an acid chemical that causes tissue damage. In children, ingestion is usually accidental. In adults, chemical ingestion is often used in a suicide attempt. So the degree of damage to the esophageal tissue ranges from pain and inability to swallow and speak to perforation and even complete destruction of the esophagus. So depending on the stage, if it's just mild esophagitis and there's just some type of general irritation, the prognosis is pretty good. However, if you get into this corrosive esophagitis, there may have to be some type of surgical intervention that is done. Esophageal cancer usually occurs in two main forms, and you can see those two main forms in the picture. Figure A, this is the esophageal cancer right here. This is known as esophageal adenocarcinoma. And then in figure B, all this tissue out here that looks necrotic, this is esophageal squamous cell carcinoma. So the esophagus is lined for most of its length with squamous epithelium, which can give rise to that squamous cell carcinoma. Adenocarcinoma may develop in the columnar epithelium near the esophagogastric junction. So what are these patients going to complain of? Well, they're going to have difficulty swallowing. They may experience weight loss, as you see in any type of cancer. Retrosternal discomfort, so pain coming from the sternum radiating to the back, and just a general burning sensation in the chest. So if the tumor involves the laryngeal nerve, the patient may lose their voice or hoarseness may occur. And the incidence of the squamous cell carcinoma is very, very high in Asia and Africa as well as Iran. So risk factors include cigarette smoking, alcohol consumption, betel nut chewing, just same thing we saw with the oral cancers, the same three main players: smoking, tobacco, consuming alcohol, and chewing the betel nut. The diagnosis, it has to be done by a physician, and they're going to detect this through endoscopic examination. Among patients who have symptoms suggestive of esophageal cancer, they may do what's known as a barium study for their initial assessment. And an endoscopic biopsy is needed in order to confirm the diagnosis. Esophageal cancer can be treated with chemotherapy and surgery, but there is a relatively poor prognosis because the esophageal cancer of both types has a high tendency for metastatic potential, even in the early stages. So the overall 5-year survival rate is actually less than 20%. One of the most severe consequences of chronic GERD is the replacement of the normal stratified squamous epithelium of the distal esophagus by abnormal columnar epithelium, and that's known as metaplasia, when one tissue type changes into another tissue type. So when we get this tissue change, we get a condition known as Barrett esophagus. And you can see the CT scan here of Barrett esophagus. In B, this is an endoscopic image of Barrett esophagus, which is showing abnormal growth of cells in the mucus lining. And then C, don't worry about it too much, but this is the histology of the Barrett esophagus, which you can see as these pink colored cells here. So with Barrett esophagus, it is very important to realize and have this diagnosis because, again, it's not necessarily the changing of the cells from one form to another. It's when those cells become cancer cells. Barrett esophagus can develop into adenocarcinoma, and that can be very, very detrimental. Should the protective mucous membrane of the stomach or the upper intestinal tract break down, the lining is prone to ulceration. These internal surface lesions can be acute or chronic. They can be clustered or singular, and shallow or deep. Deep sores develop within the deep muscle layer. And what we're going to talk about on this slide are the gastric and the duodenal peptic ulcers. So in figure A, you see a close-up view of this deep and enlarged sore in the gastric lining of a human being. B is another picture of an endoscopy. So this is a sore surrounded by this red edge. And then in figure C, this is a stained micrograph of a magnified view of a peptic ulcer that's depicted by this red spot right here. This is the peptic ulcer. So with gastric and duodenal ulcers, they don't usually cause pain again initially. So when they initially form, the patient is asymptomatic. But over time, the patient can become symptomatic. And they usually form due to excessive use of non-steroidal anti-inflammatory drugs, such as ibuprofen or Motrin. The patient may report that they're experiencing heartburn or indigestion and even epigastric pain that's described as gnawing, dull, aching, or hunger-like. The most common type of peptic ulcer is the duodenal ulcer, and this is going to be an ulcer of the first part of the small intestine, ulcer of the duodenum, hence the name. So the duodenal ulcers, well, about 2/3 of the duodenal ulcers and about 1/3 of the gastric ulcers can actually cause pain during the night that is so intense it actually wakes the patient up from their sleep. And although the cause of these ulcers is relatively unknown, other than if the patient's taken those NSAIDs and it's causing excessive irritation, another hypothesis could be that it is caused by the bacterial pathogen Helicobacter pylori, or H. pylori. So H. pylori is actually thought to be the most common worldwide human bacterial infection. And when it's present, it can produce inflammation in the mucous membrane of the gastrointestinal tract. Good news with this condition is that drug therapy is pretty good, and the prognosis overall is relatively good. Ulcers usually are resolved with simple drug therapy. Gastritis literally means inflammation of the stomach lining. So the mucosal layer of our stomach normally acts as a physical barrier to help protect us against injury, inflammation, and erosion. But when that stomach lining becomes inflamed, the patient can experience epigastric pain, indigestion, as well as a feeling of fullness after meals. Patient may also complain of nausea and vomiting, excessive burping, and a sensation of fullness from meals that wouldn't normally make the patient feel full. And just like we talked about on the previous slide with the gastric and duodenal ulcers, H. pylori can be a culprit that causes gastritis as well. So we also mentioned medications on the previous slide. So medications like the NSAIDs, they can irritate the lining of the stomach as well, so they could be a cause of gastritis. And what we actually see in this picture, this is chemical gastritis that's caused by aspirin. So you can see all these little dots. These are all indicative of gastritis or mucosal lining inflammation. And chronic gastritis kind of goes hand in hand with peptic ulcer disease. It is associated with it, and recurring exposure to these irritating substances can cause both gastritis and more peptic ulcers to form. It can also occur in patients with a history of chronic disease, such as pernicious anemia. And how do you treat this? Well, the whole thing is to get the H. pylori infection under control. So get those appropriate antibiotics against H. pylori, stop doing whatever it is that the patient is doing that may be irritating. So if the patient is taking an excessive amount of NSAIDs, remove those NSAIDs. Just remove the irritating stimuli to resolve this condition. That usually works. Gastric cancer usually occurs in the stomach. And again, just like the other pathologies that we talked about, Gastric cancer is usually initially asymptomatic. As the cancer progresses and metastasizes and gets larger, then the patient may experience weight loss and persistent abdominal pain. And again, very similar to gastritis, we're going to see nausea and vomiting. We're going to see difficulty swallowing. We're going to see that melena, those dark tarry stools, and different, we're going to actually see anorexia. So the body mass index dropping below 18.5. That is very alarming if we see a BMI drop below 18.5. Gastric cancer usually results in a palpable abdominal mass, so you can feel this. And again, excessive H. pylori infection, H. pylori that wasn't controlled. And again, don't use tobacco, don't use alcohol, because that can cause stomach cancer. As I mentioned on the slide with Barrett esophagus can transform into adenocarcinoma and other types of gastric cancer. And what do we do for gastric cancer? Well, we have to treat the underlying etiology if possible. So we're going to give antibiotics to kill off that H. pylori. They may do surgical resection if the cancer is confined to a certain area, or the patient may have to experience some type of chemoradiotherapy. Appendicitis is inflammation of the appendix, which is a narrow pouch that's about 3.5 inches long, and it extends from the first part of our large intestine, which is known as the cecum. So there's the appendix here. And in this picture, you notice on the top, this is a normal appendix, and then here you can see the inflamed and dilated appendix. So the book states that the appendix doesn't have a function. It is hypothesized that the appendix does have a function, and it is involved in the reboot theory, or the reboot hypothesis. So this is just a theory. Again, it's not definitively proven, so that's why the book says that it has no function. But what the reboot hypothesis says is that the appendix actually contains a specialized subset of bacteria that are released whenever the body is undergoing inflammation and other types of immune compromising events. So the appendix actually is thought to help ward off invaders by releasing this special subset of bacteria. Again, that hasn't been definitively proven. That's why it's called the reboot theory and not the reboot law. So again, acute appendicitis, inflammation of the appendix, and based upon the anatomical location of the appendix, that is where the patient's going to complain of the pain. So the appendix, again, it's attached to the cecum, which is located in the right lower quadrant of the stomach. So the physician may do a complete blood cell count and urinalysis, and laboratory findings may indicate an elevated white blood cell count or leukocytosis. And anytime we have an elevated white blood cell count, well, that means that the body's immune system is trying to make more white blood cells to fight off whatever pathogen is in the body. This condition is easily resolved through the process of appendectomy, or the removal of the appendix, and the appendix has to be removed if it is inflamed and undergoing this massive dilation, because if it's not removed, it can develop into peritonitis, inflammation of the peritoneum, which can lead to a life-threatening event. A hiatal hernia is a defect in the diaphragm that causes a segment of the stomach to slide into the thoracic cavity. So what is actually happening is the upper portion of the stomach is going to protrude through the esophageal opening of the diaphragm and into this thoracic cavity. And what's going to happen is the same thing that we saw in GERD. The lower esophageal sphincter is going to become weakened, and the contents of the stomach can actually get propulsed back up into the esophagus. So the lower esophageal sphincter muscle weakens, it's relaxing when it's not supposed to, it's not keeping closed when it's supposed to, and we see similar symptoms that we see in GERD. So we see chest pain, difficulty swallowing, and regurgitation. And again, the patient may complain of throwing up in their mouth. So this is a condition that is commonly caused by a congenital defect in the diaphragm or a weakness that develops in the diaphragm. So remember, the diaphragm is a muscle. If you don't use your diaphragm, if you don't exercise, the diaphragm can be weakened. Large hiatal hernias, they can be seen on a chest radiograph. but diagnosis is based on barium radiographic studies of the esophagus and the stomach. So the initial treatment is going to be aimed at identifying the symptoms and to prevent further complications. Antacids such as Maalox and Mylanta are going to be the medications that are given to the patient to control the acid secretions in the stomach. The patients may also be on proton pump inhibitors such as Prevacid or Nexium as well. An abdominal hernia is a condition in which an organ or part of an organ protrudes through or herniates through an abnormal opening in the abdominal wall. And this is usually due to weakness in the muscles and or the membranes of the abdominal wall. And there are inguinal hernias. There's direct inguinal and indirect inguinal hernias, as the inguinal canal is a common site for hernias. So what actually happens is a loop of bowel protrudes into the inguinal canal, and in a male, this may progress into the scrotal sac. And that's what we actually see in figure A up here. We see the intestine herniating into the scrotal sac. The patient may notice a lump or bulge in the inguinal area and may discover that pressing on the hernia to push it back into the abdominal cavity can actually reduce the pain. A sharp pain in the groin is continuous or made worse when the person is standing or straining. So if the abdominal hernias or the inguinal hernias are asymptomatic, they're usually left alone. But if they are causing the patient pain, they're usually repaired surgically. Crohn's disease is a chronic inflammatory disease of the alimentary canal that affects almost 500,000 people in the United States. It's also called regional enteritis. And this disease can affect all layers of the bowel and cause edema and inflammatory events in all layers. It can cause strictures, which we see in figure A, which is narrowing of the bowel. And really important to notice that any portion of the gastrointestinal tract can be affected. That's going to help you differentiate Crohn's disease from ulcerative colitis, which we're going to talk about on the next slide. So any portion of the GIT from the mouth all the way through to the anus can be affected by Crohn's disease. Patients with Crohn's disease have chronic diarrhea or crampy intermittent abdominal pain, often presenting in the right lower quadrant of the abdomen. They may also experience weight loss, general tiredness and fatigue, nausea, anorexia, fever, and abdominal fullness. In figure B, we see a close-up of the views of the sores. So all these areas that are a little bit darker, they shouldn't be there. The intestine and the integrity of the intestine should be nice and pink like we see here. So this is the unaffected area. Actually, let me go over the unaffected area in yellow so you can see what it's supposed to look like. So that nice pink color to it, where those darker areas that are circled in red are what the intestine should not look like. And then figure C is just showing you a close-up view of protruding tissues into the intestine. So a big thing about Crohn's disease is going to have what's known as skip lesions. So there's going to be segments of areas that are massively inflamed, and then it's going to skip a segment of the bowel, and then there's going to be another segment that's massively inflamed. So those are the skip lesions. And patients may have intermittent symptoms, and they may have periods of remission where they don't have any symptoms at all. We don't really know why Crohn's disease occurs or how people develop it, but it is a very devastating disease, and there is unfortunately no known cure to this as of now. So diagnosis is based on the symptoms, radiographic studies of the small and large bowels, and colonoscopy. Treatment, again, like I said, it's relatively incurable, but the treatment therapy has two main goals: to treat the acute disease as to treating the flare-ups, and to maintain remission. So a really common drug that's used, a biologic that's used to treat Crohn's disease, is known as Humira. And this is a tumor necrosis factor inhibitor. And this is one of the best drugs to keep Crohn's disease in the state of remission. So as I mentioned on the previous slide, with Crohn's disease is affecting all layers of the bowel wall and causing edema and inflammation in all of those layers. Now we're switching gears to talk about ulcerative colitis, or UC. So this is different because it doesn't affect all the layers. It affects the mucosa and the submucosa, and it does not affect it cannot affect the gastrointestinal tract in a continuous fashion from the mouth to the anus like we see in Crohn's disease. Ulcerative colitis is confined to the rectum and the colon. You will only find the areas of chronic inflammation in the rectum and in the colon in ulcerative colitis. It's a very important distinguishing characteristic. The patients may complain of bloody diarrhea. That's actually the hallmark sign of ulcerative colitis. And whenever you have blood in the stool, that is a sign to go seek medical advice immediately. The diagnosis is based on clinical symptoms, examining the stool for blood, as well as laboratory values. Again, we don't know why ulcerative colitis occurs, and unfortunately there is no cure, but there is a surgery known as a proctocolectomy, which actually what that does is it's the removal of the colon and the rectum. So the patient may have a shortened bowel, which removes the colon and the rectum. That bowel will be anastomosed to the anus, so the inflamed areas of the colon and the rectum will no longer be present, and sometimes that is effective in patients with ulcerative colitis, although that is a relatively invasive procedure because you are removing the patient's rectum and colon. Gastroenteritis is a general term for acute inflammation of the lining of the stomach and the intestines. And as we've talked about earlier, the stomach and our intestines are protected from infections and irritations because of the presence of normal bacteria, as well as the mucosal barriers and acid secretions from the healthy portions of the gastrointestinal tract. But when all of these mechanisms fail, and they fail to rid the body of toxins or large numbers of disease-causing bacteria and viruses, the stomach and intestines become filled with the products of inflammation, resulting in this pathology of gastroenteritis. The patient experiences increased intestinal motility, sometimes with the presence of mucus, pus, and blood in the stool. You may also hear this condition called traveler's diarrhea, and this is characterized by varying degrees of anorexia, abdominal cramping, frequent loose stools, and nausea and vomiting. If the infection is severe enough, fever and weakness can occur. And with any type of diarrhea, it's really important to be careful of dehydration, because with diarrhea, you're having watery stool. You're losing a lot of water, you're losing a lot of electrolytes. So it is very important to remain hydrated and make sure that you are replenishing your electrolytes as well. And it's called traveler's diarrhea because it's usually caused when the person travels by ingesting some type of contaminated food or water that their stomach may not be used to, with a higher number of bacterial pathogens or foreign bacterial pathogens that they've never experienced before. There are many different types of mechanical blockage events and pathologies that can occur, but for the purpose of this class, I just want to highlight intussusception versus volvulus. Okay, so in intussusception, what actually happens is the bowel is telescoping into itself. So the bowel is basically backing up into itself. Versus volvulus, the volvulus is a twist. It's the twisting of the bowel on itself. And you can see the area on both of these that becomes inflamed. It's not being perfused properly, and it's not getting the proper nutrients due to this constricture. So I always remember volvulus, there's a lot of V's and a lot of U's, a lot of V's, a lot of U's, a lot of twisting. So that's when the bowel twists on itself. And intussusception, it has the T, that's the telescoping. The bowel actually herniates backwards on itself, herniates into itself essentially. Now we're going to move on to diverticulosis, or diverticular disease. And this is a progressive condition common with aging, which means it gets worse as we age, that's characterized by defects in the muscular wall of the large bowel. So what we see in figure A up here, this is an endoscopic view of two sigmoid diverticula. So you see the diverticula right there and right there. Compare that with B. Compare that with this picture here. This is a gross examination of a resected sigmoid colon that's showing regularly spaced stool-filled diverticula. So all of these are the stool-filled diverticula. Figure C is a cross-section showing the outpouching of mucosa beneath the muscularis propria. So this is the outpouching. And then D, this is a photomicrograph of a sigmoid diverticulum showing protrusion of the mucosa and submucosa through the muscularis propria. So what actually happens in diverticulosis, there's outpouches of mucosa. So this is the H&E stain of the outpouching of the mucosa that penetrate the weak points in the muscular layer of the large intestine. So you actually have the diverticula actually going through the weak layer. They're protruding out where they shouldn't be. And the patients will complain about stomach pain. They may have excessive flatulence, and they may even report difficulty in defecation. The prognosis is positive unless the condition progresses to diverticulitis, which we're going to talk about on the next slide. And we don't really know why this condition occurs, just like we've seen in a lot of pathologies. We don't know why they happen, but the onset cannot be prevented. The onset cannot be prevented. But you take proper measures, you can decrease your chances of getting diverticulosis. Adequate hydration and a high fiber diet, rich in fruits and vegetables, may help constipation and may help this from forming initially at all. So again, diverticulosis has a good prognosis until it progresses into diverticulitis. This is infection of one or more of the diverticula. And this usually occurs when fecal matter becomes trapped in the diverticula, leading to that inflammation and infectious process to occur. The patient usually complains of abdominal tenderness in the left lower quadrant. That's going to be the location of the sigmoid colon. And that is where we are getting the final preparation for defecation to occur. The feces are going to go from the sigmoid colon into the rectum and then eventually down into the anus, and then we defecate. But diverticulitis, there's a lot of diverticula in the sigmoid colon, and they tend to be the ones that are inflamed due to the fecal matter being trapped. And that's why the patients complain of abdominal tenderness in the left lower quadrant. So the descending colon and the sigmoid colon, usually this is where that condition is seen. So we don't really know why this happens again, but diverticulitis, which is not nearly as common as diverticulosis, develops when there's massive inflammation and we're not clearing the feces out. So this could be due to a lack of proper fiber in the diet. This could be due to a lack of fluid intake. Lots of conditions can cause this. So antibiotics are going to be prescribed for the infection, and stool softeners may be indicated, and the physician may even encourage a liquid diet to help with the painful defecation that may occur. Colorectal cancer, as the name implies, is a cancer that arises in any part of the colon or the rectum. And this picture here is what's known as adenocarcinoma of the distal colon. The patient may complain of abdominal pain, change in their bowel habits, diarrhea, constipation, bloody stools, weakness, weight loss, a lot of the same similar conditions that we saw in the other gastrointestinal pathologies that cause irritation. Colorectal cancer is one that usually occurs in patients over 50. So after the patient turns 50, it's usually advised to get a colonoscopy every 10 years for the remainder of your life, just to monitor for any type of colon cancer. Colon cancer, there's lots of treatments for it. If it's limited and to the colon and hasn't metastasized, surgery can be used to remove it. If there is metastases, usually there's some type of chemotherapy or radiation therapy that is going to be indicated. So it really depends on the pathologic state of the cancer at the time of diagnosis. So a low stage and a low grade tumor obviously is going to have a better prognosis than a high stage and a high grade tumor. So also they look for what's known as CEA levels, carcinoembryonic antigen levels. And if those levels are greater than 5 nanograms per milliliter, that's going to give the patient a poor prognosis. Peritonitis, we mentioned this earlier in the slide where we talked about appendicitis. So this can be a result from appendicitis, but this is inflammation of the peritoneum. And it can be acute or chronic, and it can be local or generalized. So the large serous membrane that lines the abdominal cavity and folds over the visceral organs is normally transparent and sterile. But when it's irritated or infected, the peritoneum becomes hyperemic and edematous as fluid accumulates in the peritoneal space. And the inflammatory process of peritonitis has the potential to cause abscesses and adhesions to form in the abdominal cavity. So again, because the inflammation is going to be occurring, the immune system is going to be reacting. So the patient may experience an elevated white blood cell count when the doctor goes to assess the CBC, or the complete blood cell count. Abnormal serum electrolytes and abdominal extension are two other manifestations that may be present as well. Hemorrhoids are varicose dilations of a vein in the anal canal or the anal rectal area. And they are tumor-like lesions in the anal area caused by dilated veins. They're usually painless, but they can be symptomatic sometimes. So if they are symptomatic, the patient's going to complain of rectal pain, itching, protrusion, or bleeding, especially after defecation. And the patient may also report that there's mucus or there's some color discoloration of their stool. And they may also complain that they don't feel like they defecate completely. They may still feel like they have to defecate more even though they can't due to the hemorrhoid blocking the anal canal or protruding out of the anal canal, depending on whether it's an internal hemorrhoid or an external hemorrhoid. So the veins in the rectal and the anal area become varicose, swollen, and tender as a result of blockage. If they're located within the rectum, above the junction of the skin and rectal mucosa, these swollen and twisted varicosities are considered internal hemorrhoids. And that's what we see right here. These are internal hemorrhoids. Varicosities lower in the anal area covered by the skin are considered external hemorrhoids, which we see here. A large, firm subcutaneous lump indicates thrombosis of external hemorrhoids. Constipation, straining, pregnancy, and any condition that increases pressure on the veins often exacerbate this condition. So again, the diagnosis is going to be based on visual inspection, and treatment, it's a conservative treatment. So take measures to correct the constipation, prevent straining. Sometimes stool softeners are given, and the patient may be encouraged to change their diet. High fiber diet, increase your fruit and vegetable intake, and you can get the fiber from taking in more whole grain cereals. If the patient's symptomatic, warm sitz baths may be prescribed, along with a topical anesthetic ointment, which will help with the pain associated. Witch hazel compresses also work very well too. Cirrhosis of the liver is a chronic degenerative disease that is irreversible, and this is most likely caused by excessive alcohol consumption for an extended period of time. So this is going to bring a slow deterioration of the liver, resulting in the replacement of normal liver cells with hard, fibrous scar tissue. It's twice as common in men than women. Maybe that's because men have a higher tendency to consume excessive amounts of alcohol compared to women. And again, this is irreversible. It's alarming because there can be up to 40% of people with cirrhosis of the liver that are asymptomatic. But if you look over here in this picture here, these are some of the symptoms the signs that may be present in patients who are experiencing liver cirrhosis. So mental confusion and drowsiness, gynecomastia, which is the development of female breast tissue in males, especially around the areola, ascites. You can have these spider-like veins coming out of the umbilicus and distension of the abdomen. Testicular atrophy, so the testicles start to decrease in size. Skin hemorrhages can break out, and the patient can get bilateral edema, especially in the lower extremities around the feet. The hobnail liver, that is when the fibrous scar tissue is taking over and kind of remodeling the liver. And the esophageal varices, we've talked about that pathology. That can be due to throwing up excessively or just that chronic irritation over time. And again, as this is irreversible, treatment is simply aimed to prevent further damage. Now moving on to the different types of hepatitis. So this is a very important slide because I write a lot of quiz and test questions from this slide. So I want you to be able to distinguish the different types of hepatitis from one another. Hepatitis is inflammation of the liver. I also want you to add in hepatitis F out here. This is fulminant hepatitis. Fulminant, fulminant hepatitis. Any one of these hepatitises can progress to fulminant hepatitis. So hepatitis A can become fulminant all the way through hepatitis E. And fulminant hepatitis results when the liver completely fails or is in end stage. It's in its end stage and it's basically failing. All right, so let's start with hepatitis A. I'm going to teach you a little mnemonic to help you remember A and E and how they are acquired. So I always remember the vowels are in the bowels. So transmission, fecal-oral route, A and E. Those are the only ones that are transmitted through the fecal-oral route. So if you eat contaminated food or drink contaminated water, you can get hepatitis A or hepatitis E. So hepatitis A results in acute infection only. It does not progress to chronic hepatitis usually. However, there is still a small risk that we can get that fulminant hepatitis. So again, all of these hepatitises can progress to fulminant. So A and E are the ones that are going to be acquired through the fecal-oral route. And luckily, there's pretty good treatment for hepatitis A if you get this immune globulin therapy before or within 2 weeks of exposure. Most people are going to recover within 4 to 8 weeks. So I'm going to give you a diagnosis on your quiz or test question, and that'll help you understand which or differentiate which hepatitis I'm asking about. So the patients are going to make anti-HAV antibodies against this, okay? So anti-HAV. And there is a vaccine available, so HAV and HBV vaccines are both available. Hepatitis B, this is the most common cause of chronic hepatitis and liver cancer. It's the second most common cause of cirrhosis in the United States after alcohol abuse. So again, alcohol abuse is the most common cause. This is the one that is contracted via sexual contact. You can also get this through sharing needles, intravenous needles. What we're going to see on blood tests, there's going to be this hepatitis B surface antigen, or HBsAg, and that's going to help us determine that there is the presence of hepatitis B. There are some other antigens that may be present, hepatitis B E antigen and hepatitis B C antigen, but I'm going to give you the hepatitis B surface antigen on your clinical vignette. Hepatitis C, I always associate this one with intravenous drug use. Because hepatitis C, you have to see where you're injecting the drug, and shared dirty needles can result in hepatitis C contraction. So there is also the potential of this being given to you in a blood transfusion. However, blood is usually tested for hepatitis C nowadays. This was common back when blood wasn't tested for hepatitis C. And again, this is usually done through the intravenous IVD, intravenous drug use. Unfortunately, there is no vaccine against this one. Hepatitis D. Really important to know that hepatitis D cannot form without the presence of hepatitis B. So B has to progress and cause D. B does not turn into D, but B will allow D to come about. So you can be simultaneously infected with hepatitis B and hepatitis D. So again, sexual contact, same way that you get hepatitis B, can also be intravenous drug use as well. And what we're going to see are these anti-HDV antibodies. Hepatitis E, remember this is the one that's going to be contracted via the fecal-oral route. I always remember that this is epidemic. So we are in a pandemic right now. That is a global issue. Epidemic means confined to a specific country. Very rare in the United States, but people who do travel to an endemic region where this is common, certain regions in Africa, can come back with hepatitis E by eating contaminated food or drinking contaminated water. Unfortunately, there's no preventative measures, but there is a very good recombinant vaccine against hepatitis E. And again, all of these can progress to hepatitis F, fulminant hepatitis, where the liver is undergoing failure. And the last pathology that we're going to talk about, because the liver is an accessory digestive organ, it does help in the digestive process by releasing different types of enzymes. We're going to talk about liver cancer. So HCC, or hepatocellular carcinoma, is the primary tumor of the liver that usually arises in the setting of chronic liver disease. So we see HCC with several of the late-stage hepatitis as well. So with HCC, the patient's going to complain of upper abdominal pain, weight loss, fullness, and you may even be able to feel this. So this may result in a palpable abdominal mass. So it's really important to get screened for all types of cancers. And again, this is directly linked to the HBV infection. If you get HBV, you have a higher tendency to getting liver cancer.